All right, so chapter 18 is geriatric emergencies. Before we get started with that, again, just to kind of reiterate what I had sent out into the Facebook group for those of you who are watching late and didn't get the message today. Again, it's been giving you guys a lot of time to get some of these things completed, and we're way behind. The majority of the class is way behind on your quizzes. Okay, it's just unacceptable. I'm sorry. We have to get that stuff done before we can finish class. Okay, it's part of it. So Monday, barring any long-term issues with this hurricane, which I don't think there'll be anything long-term, probably some, maybe a day or two of effects or whatever if it hits us the way it says it's going to. But other than that, Monday, November 2nd, you need to have all your quizzes done. All right. So by then we'll have, like I said, today and Thursday, we'll have those done. We'll be done with all the chapters. Okay. Get those quizzes done, study those quizzes, study your books, read through your chapters, things like that. And that way we can move forward, get our skills done and all that. Again, it's very important that we get that stuff done this week and first next week, so that we can, so that we can all be at the same level when we walk in there to do skills. Okay. Again, we just don't have time to try to do a bunch of remediate. We're already teaching skills, and so we really don't have the time in that time frame to reteach things. Okay, so I need to make sure that all you guys are up there, and ready to go. Again, Rob and I both told you guys, over and over again, almost every class, twice a class, if you need assistance, if you have questions, if you're not sure about something, if you're falling behind, whatever, get with us. Let us know. Let us see how we can help you, or, some way, some form or fashion. Okay. I want you guys to succeed. I want you guys to do well. And again, like I said at the end of that thing, that's why I'm passionate about this stuff. That's why I teach it. That's why I live it almost every day. I'm treating patients. I'm doing stuff like this all the time. Okay. So, and I'm work with several of you. Okay. So again, it might be me. It might be me that you respond to, and so that's kind of important for me, because the majority of you are in Pearl River County, right? And so when we may have the opportunity to work together, or you may have the opportunity to respond to an emergency, a medical emergency, dealing with me, right? So I even more so want you all to be, switched on and confident about your skills. Okay. So anyway, moving forward, we have geriatric emergencies. So we had pediatrics the other day. We're going to move into geriatrics. Again, not a very long chapter. So again, you'll have plenty of time tonight to work on your stuff, study, that sort of thing. But just like children, we have, nuances, little things that we usually see in geriatric or elderly people that kind of give us, that will be a challenge for us at times, and of course a challenge for the patient. So we'll go ahead and start working our way through some of these things. So essentially, a geriatric patient is a patient who is older than 65 years old, right? So if a patient's 64, could they have those same problems? Sure. 60, sure. Okay. About 40.3 million people were age 65 or older in 2010. Just to kind of give you a quick statistic, I'm sure it's the numbers are a little bit different now, but nonetheless, that's of the population. 40 million people were over the age of 65. Okay, so it's a lot of people, right? In our area that we specifically live in, that is we tend to see a pretty large number of geriatric patients. So a lot of people come here to retire. They come from the big city. They come to a kind of a more suburban country setting to retire and to live and things like that. So we tend to see more of that age group in our area. So of course, just by natural causes, as we age, our body functions start to decline. It's just part of it. Okay. It's just the science of our bodies and how it works. And that's it is what it is. But everybody's different. So we try not to prejudge the physical or mental condition of an older patient. Like I said, a lot of patients, they go through a lot of things. They've been through a lot of stuff in life. You know, patients who are right now 70 years old, that sort of thing. I mean, there's, Vietnam veterans. There's, of course, you have very elderly patients that could potentially be in a World War II. And of course you have other, um, any number of different types of world issues that occurred, in between now and then, that these folks have had to endure. So, we try to give them the utmost respect and care that we can. Again, just like any other patient, right? We're going to treat them the same way. We're going to make sure we give them a complete full body examination on all patients, if it's warranted. If need be. Of course, not every call calls for that, but if need be, we're going to ensure that we are taking everything into account. And again, these folks tend to, especially when we get into level of consciousness changes and some of these other mental health issues that they might have, like dementia and things of that nature, they can do some wild stuff. They can do things that just most regular people just wouldn't do. So the potential for a lot of different wild, crazy, different types of injuries and illnesses is there. So of course, hearing and sight are those two things that we tend to lose first. And some of you may have already had to wear glasses. I've been wearing glasses since I was in the second grade. So obviously, my vision is going to be declining by the time I'm that age. So, and then of course, hearing is the other thing. Biggest thing probably in that time frame for these elderly patients that we're going to see right now is the fact that they didn't have a lot of the safety standards that we see in just general business, but in mechanical and industrial and engineering type jobs that were very prevalent and when they were younger. They basically essentially building this country. And so when that was occurring, there really wasn't a whole lot of safety standards, and so they didn't have earplugs and safety glasses, and they didn't have the internet and a safety manager to stand by the job site and tell them, hey, this is not safe, that's not good, don't look at that light, don't cover your ears while you're around this jackhammer. Okay, so later on in life, now they're developing a lot of these issues because of that. Of course, driving and walking can become hazardous, so we get a lot of fall patients. I actually went to one yesterday. 91 years old, lives by herself. She fell in the hallway, hit her head on a door frame. Had both eyes severely bruised and swollen. She was there for 3 hours before we got the call. So she had fell at 12, and it was around 3 o'clock or so when they called, and she had several scrapes and things on her hands. I believe her shoulder was dislocated. So we have a lot of it doesn't take much when you get to that age, and all it takes is a little trip and slip, trip, and fall, and to cause some serious injuries. One of the big ones that we see a lot of times is in elderly patients is, especially when it comes to hearing, is that they're, hard of hearing or deaf. And so we get people who, you end up having to yell at people almost sometimes, repeat yourself multiple times. So a lot of older adults require the use of a hearing aid. My father wears a hearing aid exclusively, 2 of them. And so he's actually looking at implants for his hearing. And so if he didn't have those hearing aids, I mean, you could stand right in front of him. He wouldn't hear what you're saying. You'd really have to literally get up next to his ear and yell into it for him to hear what you're saying. or he might hear you say, he might hear a sound, but he won't understand what the words are. So again, if it's, maybe a vehicle accident late at night, early in the morning, something like that, where maybe they don't have their hearing aids in yet, and something happens for some reason, and now all of a sudden we're interacting with this patient and they don't have their hearing aids in, something to be cognizant of. If you speak to them a couple times and they don't respond well, probably a good indication that there's something going on with their hearing. Maybe we need to, get closer, speak a little louder, or maybe write it down, something along those lines, or try to see if we can, find their hearing aids for them and let them put their hearing aids in. So another reason why we identify ourselves, hey, I'm Justin, I'm an EMT, I'm here to help you guys out, I'm here to help you, sir, what's going on with you. Now, if we do all that and we get a what, what'd you say? All right, and we're standing right in front of them, it's either a level of conscious issue or it's a hearing issue. So it should be pretty easy to tell one of the two, but if that's the case, then we probably need to simplify what we're saying, be kind of direct and to the point, and make sure that they understand what we're doing, why we're doing it, because they're not going to be picking up on all that little bitty chatter that we typically would do. So very important to ensure that they understand what you're doing and why you're doing it. So again, we try not to do it right off the bat. So just because they're elderly doesn't mean that we're going to sit there and yell at them. So again, speak in a normal voice until you have to raise your voice to a level that they can hear. Or again, you may just have to get closer to them, and that way we're not yelling so loud. There's a lot of ASL or American Sign Language is, they have a lot of different characters and ways to interpret it and everything else. And so, but there is some things that, you can pick up and learn. These are obviously just a few here, different things that you can try to learn, just like with, another language. If you just pick up a few things like, where does it hurt, or, what's your name, those types of things, for somebody who is actually deaf and who does know sign language, it's an invaluable skill to have. Even just a little bit, will help to, again, like we talked about before, about making a connection with your patient. That's a great way to make a connection with your deaf patient. So visually impaired, of course, you have adults who are just generally visually impaired, but also your elderly patients who, have glaucoma, have, other retinal, diseases of the eye, or other cancers and things like that affect the vision, and brain tumors, things of that nature. So it's definitely important to, and a lot of times they will tell you if you ask them to do certain things or what have you, they'll be able to tell you whether or not they have some type of vision issue. However, they could have a cane, use a cane, or a service dog, or something along those lines. They may need their glasses. They may be very finicky about not having their glasses. So again, another thing to be aware of and try to cooperate with. So again, if they are quite visually impaired or actually blind, like I said, they're not going to necessarily know what's going on, who you are. So if, like, we had one, going back to the deaf, we had or the fire department had a call for potential structure fire with smoke in the residence today. And oh, by the way, the caller is deaf. So she can't speak clearly at all. She definitely has somewhat of a mute type response. It's mostly grunts and things like that, and she can kind of get a few things out. But she kind of points and looks and things of that nature. So, and she's, she was probably in her late 30s, early 40s. So it's, same way, you want to ensure that we're, have some way of explaining to them what we're doing, who we are, why we're there, and being able to communicate with them. So definitely with our blind or visually impaired patients, it's important for us to kind of step by step let them know what we're doing. Hey, I'm about to touch you here. I'm about to grab this. I'm about to check your blood pressure. It's going to get tight. So all these little things that we kind of take for granted with patients who can see well. We want to ensure that we are, again, guiding them through this process. Like I said before, identify yourself. Let them know who you are. Be prepared for the are you so and so's son? Are you related to so and so? Do you know them? And a lot of times, excuse me. So a lot of times they they typically will either live alone or with in a setting that isn't very social. So when they have people around that are talking to them and interacting with them, they a lot of times they'll want to do that, and so you may have to kind of play along with that and intermingle your medical questions and your sample history questions and those types of things in there to kind of get the information that you need. But at the same time, it's not a bad way to build a rapport, but at the same time, we don't want it to interfere directly with what we're doing. And listen to the patient. Like I said, sometimes they will just kind of ramble on, especially if they have an extensive history, which a lot of elderly patients do. They'll tell you about the heart attack they had in 1992, and we're worried about, the breathing difficulty that they're having right now. So, it's not a bad idea to let them talk a little bit. But at some point, if it starts to veer away from what we're dealing with, we need to kind of wrangle it back in. And it's just again, like we've been talking about before, it's just a conversation. And so, just like any conversation, it can gravitate in a lot of different directions. So we want to just kind of wrangle that back in, steer it back into the direction that we need to, so that we can get things taken care of in a more timely manner. Again, show respect. Don't talk about the patient in front of the patient. So especially if they have difficulty hearing, they can potentially read lips. They may have adapted to that. Or if they are absolutely hearing impaired, they may for sure do that, and so definitely not a professional thing to do in any case. So if you need to say something kind of that you think might upset the patient or might be upsetting for them or something like that, you need to talk about it away from the patient and get that worked out and then come back. So of course, be patient. Just any number of different things. For any number of different reasons. They can kind of test your patience. So some of them are very sweet and kind, and some of them are very ornery, and they're upset at the world. Maybe their family doesn't interact with them very much, and they're upset about that, or loss of a loved one. Just lonely. Aggravated, things like that. So. Any number of things like that can cause them to be upset. But, like I said, be patient with them, speak to them like you would your grandparents, and you should be okay. So musculoskeletal and mobility issues, obviously we know that, we have a lot of falls and trips and things like that. So, again, especially with aging patients, we have that muscle loss, a little bit of atrophy. A lot of times they don't move around very well or very much, and so we have the atrophy of the muscle, and because that, obviously the strength is lost. The disc between the vertebrae become narrow, which causes loss of height, curvature of the spine, loss of flexibility. The bones in the skeletal system lose strength, and so they're a little bit more brittle. They're easy to break. Older people experience some loss of balance. And again, it just depends on the person, right? Uh, my dad's 70 something years old now, but it wasn't just a few years ago. He was doing Ironman triathlons. You know, um, he didn't look like, like some kind of super fit CrossFit person or whatever, because he was in his late 60s, early 70s. But nonetheless, he had the ability to do those things. He would do the whole run, bike, swim, the whole thing. And so, um, but again, as you get older, it doesn't take long when you're not doing that for those things to start to happen. So, like I said, they may not look like it, but you may have these things happen in people of all different types um, uh, of stature. So they don't have to be, shriveled up and old and hunched back and everything else to have these issues. So, like I said, that is one of the things that we go to quite often for elderly patients is falls. Um, and again, for different reasons, sometimes it's cardiac related, sometimes it's breathing related. Um, it could be, again, dementia, any of these musculoskeletal injuries, some other, pre-existing medical issue that they have, and they just they're more prone to falling. They are independent. They've been walking just fine all their life, and now they're getting to a point to where they're being restricted. They're told they can't drive. They're told they can't go here. They can't go there. They have to take this medicine at this time, all this other stuff. And so they tend to be a little rebellious, and they don't want to lose that independence. And so they want to go for a walk. They want to go for a drive, and sometimes it's just not safe for them to do that. So falls result in increased risk for brain injuries because the blood vessels are more fragile. The brain gets smaller as a person ages. So, like I said, the increased risk for a lot of different internal injuries is there. Of course, their mentation, their movements, things like that is slower, more methodical, and again, it's always a good idea. We just try to give them a hand, try to, be supportive of them, allow them enough time. They're going to be telling you, oh, I'm sorry for calling y'all out here. I'm sorry that I'm taking so long. I'm sorry. Don't worry. It's okay. It's no problem. We're here all night. We work all day, whatever it is, we're here to help you, right? We're going to, give that reassurance that they're not a burden to anybody. Cause like I said, a lot of times, all these patients, their families, after a certain point, they don't want to care for them. Everybody's busy. Everybody's got stuff to do, and also on all these other things, and they end up being at home by themselves, or after their spouse passes away, or something like that. And a lot of times they're alone, and they don't have anybody to stay with, and so they feel like they are a burden to people. So, like I said, the increased the loss of bone density often results in osteoporosis and causes those bones to be much more susceptible to breakage and fractures in general. So, of course, wrists, spine, hips, those things are really common because of the falls. And the geriatric patients may have a reduced awareness of pain. So, like I said, it's just as those body systems start to deteriorate, it starts to kind of systemically start to break down. And then when we have these falls, we have fractures and we have head injuries, which could cause other, neurophysio issues where the brain is controlling different parts of the body, and now it's starting to affect some of your internal systems and how they function. So hip fractures are a very painful injury. Most frequently occur in older women. The injured leg is usually, but not always, shortened in relation to the other leg. So hip fractures in general, or hip dislocations, things like that in general, one of the common signs that we can see upon evaluation is going to be a pretty noticeable shortening of one of the affected leg. Okay. So if you put their feet together, or if their position of comfort is with the knee kicked out and the bottom of the foot towards the other leg, which is probable, then you just put that other leg next to it, and you're going to see that it's fairly short. But again, a very painful injury, regardless of whether you're old or young. So again, we try to splint the patient in the position of comfort. So whatever the best position for them is. However, remember when we talk about the pelvic area and fractures in that area, the potential for bleeding is greatly increased. So we always have to be considerate about their blood pressure, heart rate, that sort of thing, that we're not having any internal bleeding. So again, some of these conditions, like we've been talking about: hearing loss, sight loss, loss of sensation, slowed physical movements, fractures, senility, loss of bowel or bladder control. You may have heard of adult diapers, right? So, I mean, any number of these things for different reasons. Again, just like I said, all these body systems have the potential to lose their sensitivity. So as our nerves lose that sensitivity, then the muscles, that they affect start to relax, and then you have these losses of bowel, bladder control. Some of these slowed movements, normally if you were to kind of stumble a little bit, you might be able to reach out and grab the wall and catch yourself. Well, with that slowed mentation, that slow movement, they're not able to grab themselves in time, grab the wall in time. So, little things like that are what can cause them to have injuries. So as far as medical conditions, as people get older, they're generally less able to fight off diseases. That's why, elderly people end up going to the hospital quite often. However, they really don't want, if they don't have to be in the hospital, they really don't want them there, because their immune system becomes less effective. And so, realistically, the hospital is a very germ-rich place. Even though they keep it clean and they do all this other stuff, the potential for an elderly person to contract some type of virus or some other type of what would normally be a pretty minuscule type, again, issue, disease, virus, anything like that, is going to be really bad. It could potentially be really bad for them. So we want to try to keep them out of those areas as if at all possible. The other thing too, there it says at the bottom, they have increased difficulty handling secretions. My grandfather, when he was perpetually ill when I was a child, and so he had a really difficult time. Whatever, I can't remember exactly what he had going on, but I think it's some respiratory issues and stuff like that, and so it would cause him to have a lot of phlegm and mucus buildup and things like that. And just because of the way that the nerves were and the muscles were, he didn't have the ability to essentially clear that out. So it would build up, and it would start to work its way up and try to get out. But he had no way to essentially, work that phlegm out from his chest to his, out of his mouth and things like that. So, so he ended up having to be suctioned a lot and that sort of thing, just to kind of clear those things out of the way. So, so that's again one of those things that could potentially be an issue. So again, one of those things where we always want to be monitoring the ABCs in all of these patients. So cardiovascular diseases, like we've said before, the opposite of what we're talking about with children, where typically they don't have these cardiovascular diseases and issues. These patients do, right? So they've lived a long time. They've, they either, didn't have that great of a diet. They didn't have that great of a, exercise, clean living type regimen or whatever. And so now they have hardening of the arteries, arteriosclerosis, and other types of issues that are going on within their vessels, and the heart in general is starting to lose the same muscle tone that we've been talking about. Affects the heart, so the heart is losing that muscle tone as well. The electrical activity of the heart is disrupted. Any number of things like that. So strokes, heart attacks, aneurysms, any number of these things, can be possible with these types of patients, or be more susceptible to these patients. So again, older patients have a decreased awareness or sensation to the pain. So again, if you're asking them on a scale from 1 to 10, 10 being the worst pain you've ever had in your life, what would you say this pain is? And, if they tell you, oh, well, it's about a 5 or whatever, you can probably assume that it's going to be a little bit higher than that. They're just not able to feel that. So like I said, respiratory diseases are, play a big part in these patients as well. So the alveoli loses some of its elasticity, and the muscles associated with respirations become weaker. And so therefore you get some of these acute respiratory diseases, and again, the ability for them to clear their airway and get some of that debris out of there. Patients with chronic obstructive pulmonary disease, or COPD, may live with this condition for many years. A cold or other respiratory infection can result in a medical emergency. So it doesn't take much. If you have COPD, it really doesn't take much to make it really worse, and it's already difficult a lot of times. But any of these things, just mucus build up, the inflammation of the alveoli and those lower airway issues, or lower airway areas, can definitely wreak havoc for those patients. Pneumonia is common in older patients. Again, there are a lot of times they may just not be in the right conditions. They may not take care of themselves very well, so you end up having issues where they are exposed to different types of conditions, or again, they're not able to, like I said, care for themselves as far as daily regimen of medicines and that sort of thing, and so they may develop pneumonia. So, of course, any of these older patients, if they have any congestion or possible fever, they need to be evaluated. Excuse me. Carefully examine these patients. Of course, when we're touching, pushing, poking, doing physical exams after falls, that sort of thing, really want to be careful with them. Try to secure a really good history, past and present. Like I said, we don't necessarily need to go back a really long time. If it's stuff that is kind of going to go in line with what we're dealing with, that's something we can try to revert back to. But like I said, if you kind of get them on this role of asking them about, the open-ended question of, do you have any medical problems? They're probably going to have a whole bunch of medical problems. However, 95% of them aren't going to have anything to do with what you're dealing with. So, and sometimes it could, and that's fine. But majority of the time, we want to try to narrow it down to what we're dealing with now and what their chief complaint is. So, of course, in our society, cancer is a big one. I'm sure most of us know somebody who has been affected by cancer. Again, it can strike any part of the body. Sometimes you don't get called until they really just have complications, usually later stage. So it could be anything post, like chemotherapy or radiation or any of these types of things, where they have acute pain, shortness of breath, shock, some other medical conditions that are going on with their skin, or something like that. So it really is one of those things we can't really do a whole lot about. We can try to treat some of their symptoms in the short term, just to kind of give them some comfort. So if they're shortness of breath, we may be able to get them some oxygen. Of course, if they have pain, we're not going to really be able to do a whole lot about the pain, but we can again get get all this information, get everything set up and ready to go, and get them to the hospital quickly, and so that they can help get that alleviated quickly. But nonetheless, we're going to provide that support, whatever support we can, and transport rapidly. Altered mental status. This is one, again, you deal with quite often. We deal with it almost on a weekly basis, around the county. So a lot of different reasons for it. And common cause of decreased responsiveness is lack of adequate oxygen to the brain, low blood glucose level, hypothermia. So the low blood glucose, those sugar levels are usually because they're not eating correctly. They're not taking care of themselves. It could be that they forgot to eat, and so they're starting to have a little bit of dementia or Alzheimer's or something along those lines, and they may end up forgetting to take care of themselves like that, or forgetting to take their medicine, and so we end up with issues that even cause them to have even more loss of consciousness or altered mental status. So again, we assess these patients, provide treatment according to the signs and symptoms you find. It's like I said, we have to kind of dig a little bit with family and medications and talking to the patient and that sort of thing, and we try to find out. And like I said, you could end up being where you have to talk to the neighbor because it's an elderly man. He lives by himself in an efficiency apartment, and his next door neighbor helps him feeds his cat, and takes care of him every now and then, brings him some food and stuff. And so, when they might be able to tell you all about him, because they're, his daughter and his son, they never come around, and his wife died last year. And, so just a lot of things can kind of compound, and you end up having these issues. So, so again, medications. Many older people take a large number of medications every day. You've seen the big plastic tray that has Monday through Sunday on it, and it has a bunch of pills in there, or there's just a huge, gallon Ziploc bag full of pills, pill bottles. So, like I said, they may see several doctors for several different conditions, and some of the medications might interfere with the action of other medications and cause side effects, and that might be why they're there. So we run into that where if they're on a new medicine, and that's when we get to, when we get to the Emmons sample, we usually ask that, like, hey, are you on any new medication? Did you take anything? Have you taken anything that you don't normally take? That sort of thing. And a lot of times you'll find when you do that that they have taken something new, and it may or may not be having a side effect, but nonetheless, it could start to work your way down a path as to why they are the way they are. So, of course, like I said, they may be just defiant. So they may be completely okay upstairs, but they're just defiant, and they don't want to have to take all this medicine. They don't want to be dependent on it. They don't like the way it makes them feel, and stuff like that. And so they just refuse to take it, or they, or again, like I said, they forget. Their level of attention to the little things like that are starting to diminish. And so we have to, kind of work that as sensitively as we can. However, we are not going to just give them their medicine just because they say, oh, yeah, I didn't take my medicine or whatever. Okay, well, here you go, take your medicine. Not necessarily. We never know. We can't confirm usually whether or not they actually did or didn't. So we're not just going to try to tell them to take more medicine or give them more medicine or anything like that. So not something we're gonna take part in as far as that discussion with them. It's just something where we usually try to coach them into, hey, it's a good idea. The doctor said you need to take this medicine. If you don't, we're going to have to keep coming back, and you have to keep going to the hospital. And I know you don't want to do that. So, let's just try to take your medicine when you're supposed to. Maybe, set an alarm or something like that or whatever. And, we try to give them some type of coaching or whatever to try to help them along. Again, you might have 6 bottles of the same exact thing, so we don't need to take all 6 bottles. Find the most up to date one, put that one in the bag, and then work your way down the medicines. But a lot of times, we do have patients who are being taken care of, and the family comes by and see them, or they have home health or something like that. and they'll have a list. So if they have a list of their medications, that's fine too. But again, putting all their medicines that they normally take in their little corner in the kitchen, and put them in a Ziploc bag or paper bag, and put them in the bring them with the patient. That's always a good thing. So if we get there and they go, hey, you take any medicine on a regular basis? Oh yeah, son, I take this and that and this and that for this and that. Okay. If there's a family member there, just go, hey, can you grab all those medicines and put them in a bag for me? That way you're not having to go there and do it. They usually know where things are. You don't have to rummage through their stuff, and they can find a bag for you and all that. So infections and sepsis, infectious diseases or illnesses that are caused by bacteria, viruses, fungi. They might affect different body systems, different body organs, or different organs of the body. Again, older people have weakened immune systems, and because they, again, don't take care of themselves as well, they're not as active. And then, of course, just with the general immune decline, they are they're just more susceptible to these issues. So some of these signs and symptoms vary, but some common ones: fever and fatigue, coughing, muscle aches, diarrhea. Like I said, they may not be washing their hands well. They may not be keeping their feet clean. They may not be taking showers or baths like they should. So any number of reasons why they get some of these things. Their skin is more thin. They are susceptible to cuts and skin tears, and so those can get infected. And there's just a lot of different little things like that. But one of those is sepsis, and it's a severe, potentially life-threatening complication of infection. So, you can go into septic shock, and again, it starts to affect your other body systems. So it occurs when chemicals are released into the bloodstream as a result of infection, and therefore it triggers an inflammatory response throughout the body. And then most common in older adults and people who have weakened immune systems. Like I said, it can progress to septic shock and on to death potentially. Sepsis is one of those where, like I said before, you can develop these things in the hospital. So it's definitely something you really want to try to, if you are caring for somebody or you're, you have some influence over that, make sure that they're being bathed and cleaned and, taking their medicine regularly and all that sort of stuff to try to keep these things from happening. Of course, any of those signs and symptoms of sepsis need to be evaluated. So, like I said, it doesn't take long for these things to run rampant in their body. So, we want to get them seen and evaluated as soon as possible. So we may have to, they may think they just have a little cold or they just don't feel good or whatever, but they're showing all those signs and symptoms. We need to ensure that we are, coaching them to at least have a family member take them, or let them go by ambulance so they can be seen. So patients who require long-term care, it's generally, like I said, we're going to be. A lot of times it happens. They go to long-term care after multiple times. Like we get these frequent flyers where these frequent patients who are just starting to overload our system, and it's the same people every week, multiple times a day, sometimes several times a week, almost every night, whatever it is, and they really essentially start treating us like home health aides. And not that we don't want to help, but at the same time, if we're dealing with somebody like that and you get another serious medical emergency, well, we can't just leave this patient. So we have to help them do stuff. And so it could and has taken away resources that were needed on a true emergency, when a lot of times it is some type of just nursing care issue. It's going to the bathroom, going from the bathroom to the bedroom, or getting help up off the floor, things like that. And so it really is just a lack of nursing care and an inability for them to what they refer to as activities of daily life. So they're not able to perform those activities of daily life in a safe manner, and therefore it ends up, they end up having these issues. So, however, they can, they can have almost a whole hospital room in their house, a lot of times too. And we get some of these that are very sick or ill, injured, that are, paraplegic, any of these number of things, and elderly as well, who have ventilators, oxygen devices. They might have 4 miles of oxygen tubing that is crusty and nasty and has been replaced and everything else running throughout their house. So any number of things like that. Surgically inserted breathing tubes, tracheal, breathing devices, monitors, all sorts of different things that these patients could possibly have. So, of course, if you're not trained to use those things, don't mess with them. But we get these calls for patients who need their trach cleared out. They're having difficulty breathing because they can't breathe through their trach. Their oxygen shut off or they're out of oxygen, all sorts of stuff. Of course, these patients that have these long-term cardiac issues may have implanted pacemakers, automatic defibrillators, tubes inserted into patients' arms, neck, stomach, and may provide fluids or food. So, you could have shunts like that. Catheters may drain urine from the patient's bladder, so they could have a full-time catheter inserted. So, when we're moving these patients, if we are transporting them, we're moving them around. These are pretty commonplace in the hospital, but you don't necessarily see them all the time. So, it's definitely something you want to revert to the EMTs and paramedics to kind of help make sure that we're getting everything done correctly and we're not pulling on stuff and moving things that shouldn't be moved and all that. So just have to be cautious and ask before you just, mess with that sort of stuff. There's some things, like I said, different intragastric tubes, gastric tubes, and like I said, oxygen machines, and he's got a trach. His oxygen machine goes to his trach. So again, those patients may be difficult to understand as well. They have, they have a little bit of a decreased vocal capability. So. So again, remember your role. Like I just said, a lot of these issues that they have for these long-term care patients they're really nursing care type issues. A lot of times they really aren't something that's inside of our scope. However, we do get called for them quite often. So, we'll do what we can. We'll ensure that they are, like I said, the ABCs are there and everything is intact. If we need to, treat them for some of those, we will. But essentially it's going to be, getting that, supporting that supportive care. And then if they do need to be transported, then assisting with that transport. But again, take the appropriate steps for providing care. Don't get overwhelmed or distracted by all this equipment. Question the patient and the caregivers. What is the real issue? What's the problem tonight? Why'd you call us? And not in a condescending way, but hey, why, what is the real root of the problem that we're having, and that you thought to call 911? Why do you need that? And there are plenty of them that family themselves and the family know good and well that they are straight lying to the 911 operator and telling them that they have some type of medical emergency to get you over there. And when you get there, all they need to do is get up from the toilet and go sit in their recliner. That's it. They know full well what they're doing. And so we've had to tell patients like that we're not responding to their residents anymore unless it's a true medical emergency. We've had to refer them to, social services and some other, hospice care, long-term care coordinators, patient care advocates, things like that, so that they could get that kind of home health, things like that type care. And, So we've had some that have been habitually, that would just do it all the time, because they knew that if they called 911, somebody had to come. Somebody had to at least come knock on the door and check on them, whether it was a police officer or the paramedics or, the ambulance or the fire department. Somebody had to come and make sure they're okay by law. And so they would do that. So just one of those things you have to try to, weed out those issues. So getting into some of the more psychiatric type or again mental type issues that we deal with, one of those would be in depression. Like I said, they have a loss of independence. They have maybe a loss of a loved one. They've been with for a very long time. It's more common in women than in men, but still, it may just look different in men. And again, like I said, living in some type of nursing home or assisted living facility or living alone, it's it's daunting. It takes a toll on somebody. So like I said, try to be compassionate as best you can, and give them that reassurance that everything's going to be okay. Again, decline in health, chronic health issues, constantly in and out of the hospital or some treatment facility or something like that, will also add to their depression. So, you listen for those signs of self-harm, or I don't have anything to live for. I don't, I shouldn't be here anymore. I'm really sorry to have to, for you guys to be here. You guys won't need to come back next week, or, that sort of stuff. Those little things should be little light bulbs in your head that, hey, we need to talk to this person some more, or we need to make sure that somebody is aware at the hospital. If they're going to the hospital, somebody's aware there that they have made these statements. Suicide, kind of going along with that, is generally kind of, again, like I said, coincides with that. So older men have the highest suicide rate of any age group in the United States. And so a lot of times it is because they're left alone. They, don't feel like they have anything to live for. They live their life and they really don't want to go through it meandering around an empty house, looking at the walls and having nothing to do and no one to talk to. And they just don't want to live like that. And so they'll take their own life, especially, we've had plenty of those who their spouse of 50, 60 years passed away and they just don't know how to do life. They literally don't know how to do the laundry. They don't know how to do the dishes. They don't know, especially some of these older age groups, the female in that relationship was typically a very home-based, strongly home-based type individual. And it wasn't, and to them, it wasn't some type of, negative type scenario. It was what they were, taught to do from their families and everything else. And it was something that they enjoyed doing, a lot of times. And so that's what they knew how to do. And so that was, so for them to transition from, relying on this person for all these things, and now all of a sudden they're gone. A lot of times they're just, again, like I said, they really just are embarrassed. They're confused, and they don't want to live life like that. And so they'll end up taking their life. Like I said, listen carefully. Listen for those signs of depression or statements about suicide, those types of things. Or if it is an attempted suicide, obviously that's a big cry for help a lot of times. So we want to, give that its due regard and make sure that we are trying to get them some help. Dementia, like I said, it's a more of a pattern of decline in mental function. They typically have memory loss, may result in decreases in reasoning, judgment, comprehension, ability to communicate verbally. So it just kind of depends on what level it is. And, it would just be flashes, right? So it'd be flashes of understanding, so when somebody called you because, Mr. Smith is, talking all crazy and doesn't understand what's going on and everything else. And 15 minutes later, when you get there, he can answer questions appropriately. He knows where he's at. He knows what's going on, or whatever. And it's a toss up whether or not that dementia kicks back in and he starts not being able to answer questions appropriately, or doesn't know these things, or starts being, looking at you all funny, like, why are you here? What's going on? That sort of thing. And, or it could, like I said, it could be straight laced long enough for you to leave. And then, 15 minutes after that, and he's, has another type of episode. So that's something that happens occasionally, and it's frustrating because there's nothing we can do about it, because at the time that we're there, he's alert and oriented to person, place, and time, right? So his level of consciousness is there, and we can't legally kidnap him, right? So we don't, so it's frustrating when those things happen. So, like I said, we're definitely want to make sure that we ask those questions. Where you're at, what year it is, who the president is, those types of questions. Do you know who this person is that's staying in here? That sort of stuff, and try to get. They may not know that they fell. They go, how did I get all this blood on me? Why is this blood? Why am I bloody? Did you beat me up? What's going on? And so, no, sir, you fell down, right? So sometimes we have to kind of give them a little bit, but at the same time, we can quiz them, so we can use that. Hey, you said you don't remember falling. Did you hit your head? No, I don't remember anything. I don't think I hit my head. My head feels fine. All right. So we can start to kind of build a case for us to take them, maybe at that time, what would be essentially against their will, but medically they would meet the criteria for not being able to answer those questions appropriately. So 20-40% of people older than 85 years have some degree of dementia. You find those 85-year-olds that are sharp as a tack. They can tell you everything about the Korean War and the Depression and all this other sort of stuff. They know everybody's name. They remember every place they lived, every vehicle they owned, every job they had, every coworker they had, all this stuff, right? They can tell you everything. All about the kids and what the kids did, and what the kids do now, what the grandkids and great grandkids do, and all that stuff, right? And the next person, they barely have any of it. They can tell you maybe about their immediate family and close friends and stuff like that, but they don't have very, and sometimes it's short term. They may have, they may be able to tell you in flashes the same thing. They'll be able to tell you a little bit here and there, and then go, I don't remember all. I can't tell you. I don't remember, or whatever. And then, I don't know who that is. And then, if they sit there and look at them long enough, they go, yeah, that's Jason. Yeah, I know Jason. He goes to my church, right? So little things like that you have to kind of look out for. Causes of dementia: small strokes. So if we have TIAs, transient ischemic attacks, or strokes, they could damage parts of the brain, that memory section, and things of that nature, cognitive ability section. So hardening of the arteries, that arteriosclerosis, and then heredity could have that as well. But those hardening of the arteries generally just decreases blood flow to those areas of the brain, so that we have issues with that, getting oxygen-rich blood to that part of the brain, which would in turn cause them to have those issues. So Alzheimer's is the most common type of dementia. So they're kind of one and the same. Chronic degenerative disorder that attacks the brain and results in impaired memory, behavior, and thinking. Again, Alzheimer's patients, sometimes they'll live in a completely different era of life. They may not remember anything before 10 years ago, or they don't know anything that happened after, up till, they live maybe like 1986 to 1996. They might be living in that era. They remember people, they remember places in that era, and they don't, they really don't know what's going on actually right now. So a plethora of things that you have to deal with Alzheimer's. So again, it's very similar. Of course, it is a stage of dementia, so it is something that all those same things apply. And In the terminal stages, in the late stages, patients may be unable to walk, lose control of their bowels and bladder, become unable to swallow. Again, you'll just be, those are some of those ones that will progress into just a blank stare, so they may go from slight memory loss to great memory loss to, loss of some of their behavioral, capabilities. So they lash out at people, or they start crying all of a sudden, screaming, that sort of stuff, and yelling, cursing, that sort of thing. And sometimes, like I said, they'll have flashes back to normalcy, and they'll realize that they did some of these things, and it scares them so bad. And so then the time spent in that phase of normalcy is spent in a, oh my God, what is going on? I'm so scared. I don't know what's happening. And then, again, very soon they may slip back into that Alzheimer's type state. So it's a very painful thing to watch somebody degrade into as a friend or family member, and especially long-term care providers, that sort of thing. So again, speak clearly and use the patient's name. Let the patient know what you are doing at each step of your assessment and treatment. So just because they are talking out of their head, or they're not acting appropriately or whatever, doesn't mean you just get to say whatever and do whatever. Okay, it doesn't give you free rein to do that. You still, yes sir, yes ma'am, this is what we're doing, you mind if I touch you here, we'd like to take you and get you looked at, get you checked out, and that sort of thing. We're just going to take a ride in the ambulance, whatever the process is, walk them through it, talk to them about it. Again, we're treating, they're people, they're adults, and so we're going to treat them with that same respect that we would anybody else. However, there may not be very much that we can do for them. There may not be a whole lot of supportive care, actual medical interventions that we're really going to be able to do for them. So again, when we're caring for these patients, we also try to get as much information from the friends or family that we can. If you are asking the patient, a lot of times it's good to verify, because again, they may go way off left field with this information, and it could sound right. It could sound like it could be right, and you're like, the way they've been talking before, the way they said they were talking earlier today, I don't know if I can trust this information. So you may have to bounce it off of a friend or family member and go, hey, what do you think about that? You think that's the right thing? And a lot of times they'll either give you the right information, or go, no, my daddy died in 1975 when he was, 40 or whatever, and I don't know what mom was talking about. That's nowhere near right, So, she never did work at the, the feed store. She worked at the hospital, as a nurse, or something like that, So could be any number of wild tales, that they spit out there, but they may spit it out in a very eloquent way. All right, so don't get wrapped up in that. So hospice care is a healthcare program that brings together a variety of caregivers, provide physical, emotional, spiritual, social, and economic care for patients who have terminal illnesses and who are expected to die within the next 6 months. Like I said, it's just kind of a hodgepodge of, depending on the patient, of different specialties, to ensure that, they try to, give the patient some type of comfort and reasonable amount of care, to keep their quality of life at a decent level, until they pass away. So a lot of times it's big on like pain relief, emotional support. So you could have anything from oral medication, special pain relieving patches, transdermal medication patches, medicine that's placed between the mouth and the gum. The gum and the cheek, in the mouth. So EMS is usually called when the patient experiences unexpected problems such as shortness of breath. So it's usually something where, they don't have a solution for it yet. They don't know that they need something for it yet. And usually a lot of times it's when they're first starting hospice and they get on there, and then all of a sudden they wake up in the middle of the night and they're having shortness of breath or chest pain or something like that. And usually, like I said, early on, the family is usually hasn't come to terms with that yet. And so they will call you for every little thing. And a lot of times, like I said, they are generally they're essentially in a hospital type setting, but they're at home. And so not every family or support base understands how to deal with that yet. And so early on, they'll call you for everything, just kind of like a newborn. They'll call you for every little thing possible. And again, a lot of times you're not able to do very much for them, so they end up going back and forth to the hospital until they can get everything tweaked to where it kind of works out. So we try to, these advanced directives usually accompany these hospice patients, and essentially one of the big ones is DNR, but an advanced directive is essentially a document that outlines the care patients want to receive if they are not able to make their own medical decisions. So sometimes they'll set powers of attorney for family members or next of kin or something like that, so that they are the ones who get to decide what happens. Or they may say, I don't care what my wife says, I don't care what my sister says, I don't care what my mother says. If I mentally can't make my own decisions, I don't want to be on a ventilator. I don't want to be resuscitated. I don't want to receive CPR. I don't want to receive any chest tubes or, endotracheal tubes or anything like that. So essentially that's what a DNR is. It's an order, is a request to withhold CPR and other life-saving measures if a person's heart stops or if he or she stops breathing. So it's important for you to know the regulations concerning these documents in your state. If you cannot determine whether an advance directive is valid, begin appropriate medical care and leave the questions to physicians. Okay? So big one is if they have a DNR, it needs to be signed and it needs to be within date. So if the parties involved haven't signed it, usually the doctor, the attorney, the patient, that sort of thing, if they haven't signed it and it's within, it'll have an issue date and a valid to date. So if it's not within that date range, then it's not valid. Okay. So again, family may not pay attention to that, and they say, this is daddy's DNR right here. I got it. Don't do anything. You look at it and go, ma'am, I'm sorry, but this went out last week. It is not valid. I have to, by law, continue this care. I have to. They don't get to tell you what to do after that. Okay. So again, just because they're the family, just because that's their wishes, does not give them the authority to tell you what to do with that patient's care. Okay. If they, you have a legal obligation to render aid to that person. Okay. So again, it needs to be, that document needs to be signed, needs to be, and it needs to be correct and in that correct date range. Elder abuse, again, this is something that you see. You see it at hospitals, you see it at nursing homes, especially. Not all people at nursing homes really care. They need a job. It's maybe something easy for them, and so they just they really don't have a concern for the elderly or the the mentally ill and that sort of thing, and so they end up getting frustrated because it is frustrating dealing with some of these patients. They like I said, you have to be patient, you have to be understanding. And so for some people who don't have that and don't really understand or don't want to understand, it's annoying, it's upsetting to them that they have to work around these people and all this other stuff. So again, they they'll take it out on them. And again, it could be the spouse, could be a family member, could like I said, a lot of times it is a caregiver. Could be physical, could be sexual, emotional, or financial. So again, these people sometimes have their life fortunes or whatever that are on some type of, documentation or card or, something like that can be exploited by somebody who has close contact with them. So, and again, as bad as it is in a sexual way, that's, some people are weird like that and will do, all sorts of, not necessarily gratifying, but just mean things, so physical abuse, emotional abuse, things like that, withholding food, not caring for them, not bathing them, that sort of stuff. Just like any other type of abuse, so you have bruises, burns, trauma in the genital area, signs of neglect, like I said, not being bathed, not being turned, so they're having bed sores. Now, again, that's some of these things like bruises and things like that are tough because, again, you get somebody like this person here. I mean, they probably could cough hard and have a bruise or have a skin tear or be have a little cut or something like that. So you really have to make sure that you know what you're dealing with, and if there's a doubt, bring it up, let somebody know, and see if somebody can investigate it, and make somebody tell you how that happened, but or make somebody tell the investigators how it happened. But nonetheless, let law enforcement and the hospital staff and things like that know. So again, not a very long chapter, but again, nonetheless, a very challenging group of people to have to, have to work with, and it's, like I said, just like children, there's a lot of these little nuances that maybe come together, or just, especially at first they may just have, one or two little issues here and there, and then after a while they usually will compound, especially if they start to have some type of other just medical issue, so some type of cardiovascular issue or breathing problem or something like that, and then that kind of puts them in a bed or puts them in a prolonged situation where they are, they're not moving very much, they're not very active anymore, they can't care for themselves very well because of it, and so they end up having some of these issues. Again, you could have somebody who's 30 years old and gets in a serious vehicle accident or ATV accident and has a serious brain injury, who will essentially be the same exact way. They'll exhibit the majority of these things as well. Okay, so but again, with the elderly folks, we try to be as understanding and compassionate as we can. Again, like I said, you'll have some that are devious and defiant and everything else, and sometimes you have to take a little bit of a hard line to them. And if it's you kind of have to let them know that you're not going to be pushed around or whatever just because you're younger than they are, and you're not going to they don't get to just tell you or make you do whatever it is they want to do, right? So so sometimes we have to have a little bit of a talking to with them, almost like a child, and so, like I said, a lot of times that's just because they're frustrated and they're upset at their issues that they're having, and it's usually not a personal thing. So we try not to take those things personally, and we try to find common ground and a way to move forward. So, anybody have any questions with that? All right. Like I said, next week, Thursday, we have our last classroom chapter, and that'll be incident management, chapter 21. So the class code for tonight is going to be R0014. R0014. All right. If nobody has anything else, I'll see y'all on Thursday.